All right. Thank you, Felicia, for leading us through that break and for the practice of self-care. That's very much needed, especially as we discuss all of these difficult topics. So, hello, everyone. My name is Angie Lorenzo, and I am the Chief for the Office of Women's Health at the Arizona Department of Health Services. In this session, the importance of preconception and interconception health on maternal and infant health outcomes. We're going to talk about some of the other risk factors that are highlighted in the PPOR analysis, previous preterm births and inadequate weight gain. So, next slide, please. So oftentimes the drivers of poor health outcomes for mothers and infants is related to optimizing women's health and management of chronic conditions before, during, and after pregnancy. You heard from Edith, Dr. Salick, and Brianne already, who touched on the importance of access to care to support health outcomes. This session is focused on the care that women receive specifically, mostly to help women to be as healthy as they can be before, during, and between pregnancies. I'm going to start by sharing some data related to the health outcomes for some of the most common chronic conditions among mothers in our state. And then I will introduce our guests, Dr. Lin, Dr. Gilliam, and Julia Wacloff, who are going to describe opportunities to improve health outcomes for Arizona's mothers and infants. Next slide. To start off, we're going to share some data related to maternal mortality from our latest maternal mortality and morbidity report in Arizona that was published this past December 2020 and includes valuable information on 134 maternal deaths. The chart here is showing the leading causes of death among pregnancy-related deaths in Arizona between 2016 and 2017. As you can see, the two leading categories for maternal mortality have to do with cardiovascular, coronary, and cerebral vascular conditions, as well as conditions of pregnancy, which are preeclampsia and eclampsia, or hypertension disorders of pregnancy. This further emphasized the need to discuss chronic disease prevention and management strategies to support women before, during, in between, and after pregnancies. We also want to show some data related to severe maternal morbidity, or SMM. Severe maternal morbidity is basically the unexpected outcomes of labor and delivery, such as hemorrhage, organ failure, or stroke, that lead to significant consequences on a woman's health. When we talk about SMM, we are talking about severe things that occur during labor and delivery where the woman may not have died, but we want to make sure we are preventing it from happening again or to other women. There were a total of 3,547 SMM cases found between 2016 and 2019. In Arizona, 119 of every 10,000 delivery hospitalizations is an SMM case. We have a few slides that show rates of severe maternal morbidity when various conditions are occurring. All of the severe maternal morbidity data is showing outcomes for 2016 to 2019 combined. First is severe maternal morbidity by pre-pregnancy body mass index. This is showing us that being underweight and being obese both resulted in higher rates of severe maternal morbidity for births with only one child in our state. Next slide, please. The next set of data shows us SMM rates by two key chronic conditions that are prevalent in Arizona: diabetes and hypertension, or high blood pressure. You can see for both conditions, women with diabetes or hypertension have higher severe maternal morbidity rates or worse outcomes during labor and delivery than women who don't have those conditions. Next slide. In this session, we are also talking about interconception care. So this slide shows us severe maternal morbidity rates by interpregnancy interval, or the time that goes by between the previous birth and the conception of the next pregnancy. You can see by this graph, pregnancies that occur very soon after a previous birth, 11 months or less, and pregnancies that occur a long time after a previous birth, 3 years or more, have worse health outcomes than those that become pregnant between 1 and 3 years after their previous birth. Again, all of this is just showing us why it's important to support women in planning and optimizing their health between pregnancies. Next slide. When we look at how severe maternal morbidity in moms is impacting infant health outcomes, we see a few things. Women who experienced severe maternal morbidity during their labor and deliveries were much more likely to have a baby with a low birth weight, a low APGAR score, meaning the condition of the newborn infant immediately after birth, a score less than 7 is considered abnormal, and a higher likelihood of NICU admission. Next slide. The combined infant mortality rate for preterm infants, those born less than 37 weeks gestation, was 3.33 per 1,000 live births, meaning that for every 1,000 babies, approximately 3.3 of them pass away prior to their first birthday. The combined infant mortality rate for low birth weight infants, less than 2,500 grams, was 1.98 per 1,000 births. Next slide. Finally, this graph shows us the top 3 causes of deaths for infants. The most prominent cause of death among infants was prematurity, comprising 37% of all infant deaths from 2015 to 2019. The second highest cause of death among infants was congenital anomaly, comprising 18% of all infant deaths from 2015 to 2019. Sudden unexpected infant death, or SUID, was the third most prominent cause of death for infants, comprising 17% of all infant deaths. As a reminder, prematurity and SUID are conditions and causes of death that attribute to Arizona's excessive mortality in Black and Indigenous infants. Next slide. All right. So before I introduce our first speaker and really get into the meat of our session, just want to remind everyone that full speaker bios are located in the app, in the HOVA app, if you'd like to learn more about those that you are going to hear from today. Their slide decks are also located in that same app, and they're labeled by their names. We're also going to hold all questions for the end of the session, but feel free to begin to input them into the Q&A section on Zoom at any point. All right, so now I'd like to turn it over to our first speaker, Dr. Monique Lin, who is a maternal fetal medicine specialist for Mountain Park Health, where she focuses on optimizing the health of all of her patients before, during, and after pregnancy. Dr. Lin, take it away.
Good morning, or good afternoon, everyone. Thank you, Angie, for the gracious introduction. And I hope everyone has enjoyed the morning sessions as much as I have. I would like to thank the organizers of the Arizona Maternal and Infant Mortality Summit for inviting me to speak this afternoon. I hope that in the next few minutes, I can introduce a framework that will allow us to have a robust discussion about preconception health and its importance in decreasing maternal and infant morbidity and mortality. Over the next 15 minutes, I would like to review the rationale for preconception health interventions to address infant mortality, discuss the theory of developmental origins of health and disease, or Dohat, and discuss strategies for effective preconception health interventions. We had an excellent discussion this morning on the perinatal periods of risk analysis performed by the ADHS team to inform us of possible targets to address excess perinatal and infant mortality. In this analysis, very low birth weight infants were found to be an important group that contribute to the excess burden of infant morbidity and mortality. Pregnancy factors identified in the PPOR analysis that increase the risk of very low birth weight infants included inadequate weight gain, multiple gestation, prior preterm birth, and no prenatal care. Although a woman's life cycle is much more complex, if framed in terms of pregnancy, during her reproductive years, a woman is either pregnant or in the interconception, preconception period. As soon as she delivers, she's in the preconception period. If she has a female child, as an adult, she will also have her own cycle of pregnancy and interconception care. Another way to frame this cycle is in terms of pregnancy trimesters. Pregnancy is represented by the first through third trimesters, and the fourth trimester, which is increasingly important focus of women's health, is the interconception preconception period. I would suggest that the fourth trimester should not end at 6 to 8 weeks postpartum, or even 6 months or a year postpartum, but rather continue until the start of the next pregnancy. As we explore interventions that may impact inadequate weight gain in pregnancy, multiple gestations, and the resulting pregnancy complications, history of prior preterm delivery, and barriers to prenatal care, our instincts would suggest that we should focus on pregnancy interventions. Like growing a vegetable garden, any changes you make to your garden after it has started to grow may not be as impactful as the work that goes into preparing the garden before the first seed is planted. There are so many factors that affect the quality of the soil, the microclimate of the garden, air quality for the plants, presence of weeds, etc. Similarly, the social determinants of health, maternal health conditions, maternal mood disorders, or trauma are part of a large list of important influences that can impact a pregnancy even before it begins. In the next set of slides, I would like to explore a theory that helps explain how maternal preconception health via the intrauterine environment is impacting the health of her offspring. The theory is called Dohat, or the developmental origins of health and disease. The theory is best summarized as the following. Environmental exposures at critical time windows in fetal and newborn life lead to changes in the expression of an individual's genetic code, such that the individual, as an adult, is at higher risk for chronic, non-communicable diseases. This is a powerful idea. What happens to our moms while we are in the womb changes how our DNA is expressed and charts the course for our health or illness as adults. Because these are changes in how our genetic code is expressed, these changes can be cumulative and passed from one generation to another. Let's unpack this idea further. This list is not exhaustive, but as you can see, environmental factors is a broad category. It includes the effects of BPA, pesticides, and other chemicals in food, environmental pollution, medications, smoking, drug use, a highly processed maternal diet, maternal stress and mood disorders, social determinants of health, maternal diseases such as hypertension, diabetes, sleep apnea, and other conditions. These factors, through epigenetic modifications, alter the expression of our genetic code. Importantly, the original genetic code, the library of our genes, is not changed. However, which genes are active and inactive and at which time in our lives is altered by these environmental influences and are passed on to subsequent generations. Imagine if our genetic code was a choose your own adventure book, and I'm old enough to have read them. The letters and words of the book have not changed, but the order in which the book is read is changed and thus altering the storyline. Now, imagine if the story, because of these epigenetic modifications, could only be read in a certain fixed way, and that storyline is passed on and possibly further altered by the next generation of epigenetic changes. This is the proposed theory of how preconception maternal factors are leading to inherited changes in gene expression that are manifested in offspring when we are children and we grow up to be adults. This is really powerful. So let's look at some examples of the Dohat theory in action. David Barker, a physician and epidemiologist, published a study in 1992 suggesting a correlation between low birth weight infants and cardiovascular disease in adulthood. He had noted that at the time, at the same neighborhoods in England in the earliest 20th century that had a high rate of adult death from cardiovascular disease, also had a high rate of infant mortality. Infant mortality at that time was primarily driven by low birth weight infants. Barker hypothesized that low birth weight infants who survived to adulthood were at increased risk of cardiovascular disease. More robust studies since that time have borne out these observations. The Dohat theory would suggest that fetuses with nutritional deprivation develop a thrifty genotype in utero. After they're born into a world of plenty, these adaptations that were important in utero now lead to an increased risk of obesity, hypertension, and diabetes. Another example of the Dohat theory in action is the effects of maternal high-fat diet on the health of her offspring. These data were collected in a series of experiments in non-human primates. Normal weight, pregnant, Japanese macaques were fed normal chow throughout pregnancy, or the equivalent of a maternal high-fat diet throughout pregnancy. I tell patients this is equivalent to eating your favorite fast food restaurant every day. Infants of mothers who ate a high-fat diet not only weighed more at the time of delivery, but also had a higher percent body fat mass. As adults, these offspring were at higher risk for obesity, hypertension, and diabetes. Genetic analysis of these animals suggested that epigenetic changes in the genes that control circadian rhythm or your sleep-wake cycle were observed. Circadian rhythm is very important in the regulation of your metabolism, amongst other things. And in our last example of the Dohat theory in action, we know that 10 to 20% of women struggle with mood disorders during pregnancy, and that percentage can increase to 30 to 40% in disadvantaged and low-income women. Multiple studies suggest that through alterations in the hormonal stress response of the fetus, maternal stress and mood disorders increase the risk of early delivery, small fetal size, but also increase the risk of depression, anxiety, possibly schizophrenia, and ADHD in the child. Maternal mood may be tied to many other influences, including sleep, nutrition, food insecurity, and other social determinants of health that may also have a direct role in epigenetic modifications. Thus, if interventions during pregnancy may be enacted too late to affect short and long-term child and adult outcomes, do preconception, or again, that fourth trimester strategies work, and how can they be implemented? There are limited studies on the efficacy of preconception interventions to affect maternal and newborn health. Strategies to affect behavior change must impact the targeted population by individual, environmental, or social approaches. Women who are seeking pregnancy will more readily access preconception services, and individual strategies are important in this context. Increasing the awareness of women to the importance and availability of preconception care is vital. In women not actively planning pregnancy, their contact with the women's healthcare provider is often rare and unpredictable. Potential strategies to improve preconception health will need to be multi-layered. It may involve a social movement to change our national perspective about the fourth trimester, including its duration and its importance. It may include a campaign in schools educating all healthcare and public health workers about the importance of preconception health, and to take advantage of that routine contact between women and any healthcare provider as a time to intervene. Other strategies that have demonstrated success are food fortification programs, such as folic acid to decrease the rate of spina bifida, or targeted micronutrient supplementation prior to pregnancy in low-income countries. In communities identified to be at high risk for micronutrient deficiency before pregnancy, local and state programs should target supplementation in those high-risk communities. Local and state programs addressing access to safe and affordable housing, transportation, high-quality food, affordable childcare, access to education, access to mental health treatment, and other social determinants of health are also invaluable for robust preconception health. As an example, let's return to one of the maternal factors identified in the PPOR analysis, prior preterm birth. A meta-analysis of risk factors for a prior preterm birth identified the ones listed on this slide as modifiable ones that, if impacted, would decrease the risk of preterm delivery. Management of infectious diseases and chronic health conditions would be amenable to intervention by any healthcare provider, whereas micronutrient deficiency may be impacting by addressing food insecurity. Pre-pregnancy BMI, intimate partner violence may be better approached through an individual and community or state level program. All these factors are amenable to preconception intervention. In conclusion, the maternal environment, in the broadest sense of the word, including maternal diet, maternal health, maternal stressors, can alter the expression of genes of her offspring. Perinatal stress through direct fetal effects can increase the risk of a low birth weight infant and preterm delivery. To change our national mindset and conversation surrounding preconception health, I suggest that the fourth trimester should start at delivery and end with the start of the next pregnancy. It's incumbent on every primary healthcare provider that cares for women, not just women's healthcare providers, to address maternal health and social determinants of health in the framework of a subsequent pregnancy, and to recognize the urgency with which these concerns need to be addressed. And finally, a multi-level approach to preconception health and interventions is necessary to effect change. No single strategy is sufficient. Thank you so much. And with that, at the end of the session, we'll take questions.
All right. Thank you, Dr. Lin. That was excellent and awesome information that you provided so that we can support moms in achieving healthier pregnancies in the preconception period. So next, I would like to introduce Dr. Danielle Gilliam, who is the president of the American Diabetes Association Community Leadership Board Phoenix chapter, the health chair for the NAACP Arizona State Conference, and the board member at large for the Arizona Obesity Organization. Dr. Gilliam is going to share more about how we can support mothers as it relates to conditions such as obesity, diabetes, and hypertension. Take it away, Dr. Gilliam.
Thanks, Dr. Gilliam. There's a mic up.
Yes, it's not sharing properly for me. Sorry, everyone. Let's try this again. Okay. Please let me know if it is now sharing properly.
Okay, we're gonna take it. You got a mic up because.
Am I giving feedback? I'll take that as a no. Good afternoon, everyone. Thank you, Dr. Lin, for sharing that valuable information on maternal preconception health. You know, every day, over 800 women die from preventable causes related to pregnancy and childbirth. Some of those causes are the prevention and management of chronic conditions like obesity, diabetes, and high blood pressure, which you have already heard from other speakers. So right now, the time is around 1:25 p.m. in Arizona, which means that half of our day has already passed. More importantly, it means that over 400 women have died as of now from a preventable cause related to pregnancy and childbirth. So let's talk about this. Let's talk about the maternal and infant health outcomes as it relates to chronic conditions and how we can have an impact. Maternal health outcomes and chronic health conditions. Sorry, one moment. I'm hoping that you can see everything okay. Maternal health and outcome chronic conditions talks to how women with chronic health conditions can have healthy pregnancies and healthy babies. They can have healthy pregnancies and healthy babies. Chronic health conditions include asthma, diabetes, high blood pressure, obesity, mental health conditions. Partner with healthcare providers, whether they're your MDs or nurse practitioners or PAs, healthcare providers, to help manage chronic health conditions and treatments, including medicine, before, during, and after pregnancy. Don't stop or start taking any new prescription medicines before, during, or after pregnancy without first speaking to your healthcare provider. And then taking some medications during pregnancy can cause serious problems, including premature birth, NAS, and also birth defects. What are some of the chronic health conditions? What are some of the issues that chronic health conditions can increase? Well, infertility, for one, premature birth. Birth defects can also be influenced here. And then also pregnancy loss, like miscarriage and stillbirth. All of these can be increased if chronic health conditions are either unmanaged or uncontrolled, or actually occur during pregnancy. So let's talk about something that I'm very passionate about, and this is obesity. In the US, up to 60% of women are overweight at conception, over 60%. And roughly about 30% have, women are overweight at conception, and roughly 30% have obesity. And I'm defining that as having a BMI of 30 or more. So that whole thing about, remember when you used to say, oh, well, I'm eating for two? We don't want to eat for two, depending on where your baseline is. So if your baseline is at overweight, then, just eat regularly, eat for one. And then if your baseline is slightly higher, then you need to have a plan of action with your provider into how you don't necessarily want to lose weight during pregnancy. That would not be good. But you definitely don't want to have as much weight gain during pregnancy, because obesity is associated with an increased risk of almost all pregnancy complications. And we mentioned a few on the previous slide. And mothers with obesity are more likely to have other comorbidities like diabetes, high blood pressure, elevated cholesterol levels, and sleep apnea. And as a mother, I know how hard it is already to sleep with that big belly and the baby moving around inside of you. So sleep apnea could actually even worsen. Obesity also increases the risk of cesarean birth, so C-section births, which can lead to infection, bleeding, and other complications. Let's talk about something that is important to also share in regards to a mom having excess weight during pregnancy. What does that mean for the infant? Well, evidence actually implicates that epigenetics, which you heard Dr. Lin speak to already, is one of the mechanisms in the regulation of postnatal environment and their ability to transmit to future generations. And so in a nutshell, what is epigenetics? Simplified, it means how your behaviors and environment can actually cause changes that affect the way your genes work. Now, this doesn't change your DNA sequencing, but it actually does have an effect on things postnatal environment. So things like breastfeeding versus formula, excess calories, the westernized diet that we all love because it's quick and easy, but there's some other things that come with that. And then also inactivity. So let's walk through this process. This is a very busy slide, but let's walk through it. The number of infants and young children with overweight or obesity has tripled between 1990 and 2012. This is the data that I'm referencing. And is rising in parallel with rates of maternal obesity. So as maternal obesity goes up, infant obesity goes up, which speaks to, again, what we were talking about, the epigenetics. And given that half of childhood obesity occurs by the age of 5, early life events may be contributing to pediatric obesity development. So many studies have actually reported there's a strong association between intrauterine exposure to maternal obesity and excess weight associated with, excess weight with the child at birth. There's also intrauterine exposure to maternal obesity that can increase obesity comorbidities in offspring, such as insulin resistance. And I'm not sure if you're familiar with that term, but if you think back to diabetes, especially type 2 diabetes, that actually usually precedes the diagnosis of type 2 diabetes. There's also different changes in the mitochondrial function, but we won't have that discussion here today. But what I will say is that childhood obesity, what it does do is it increases the chances of the child having other things like fatty liver disease and cardiovascular disease. And actually, there was a study that showed the newborns at 2 weeks of age who were born to mothers who had excess weight and gestational diabetes, they actually demonstrated 68% more lipid fat compared to newborns of normal weight mothers. And this was directly correlated to maternal BMI. Now, what does that mean? That means that that's that fatty liver disease. I don't know if you've heard that. That's what the NAFLD is standing for. But that is now becoming the #1 reason to liver transplant in the US. The #1 reason. It has surpassed alcoholism. The powerful influence of the intrauterine environment is characterized by nutrient excess and obesity. And it's also underscored by the marked decrease in the risk of obesity in children born to women with obesity who underwent bariatric surgery. So what does that mean? Well, that means that if you had a mom who prior to having or becoming pregnant underwent a certain treatment for excess weight, bariatric surgery, once they had their child, there was actually a decreased risk of obesity that was seen versus mothers who had excess weight that did not have that surgery. And I just say all of this to say is that there is a lot of evidence here that speaks to why this fetal programming actually does exist and how we need to have conversations with mom pre-conception and really try and change the outcome. Now, being overweight and obese, or having obesity, I should say, before or throughout pregnancy is a major risk factor for yet something else, diabetes during pregnancy. Well, 20 to 30% of women do develop gestational diabetes that are not actually obese. They don't have obesity. They still develop gestational diabetes. So we know that there's other factors that are in play around pregnancy. And again, I talked about the insulin resistance. That's probably playing the largest role. But diabetes during pregnancy has actually continued to increase, and it's been correlated to changes in our lifestyle and our food choices. Diabetes is diagnosed before pregnancy increases infants' risk for congenital abnormalities, stillbirth, and actually being large for gestational age. We already talked a little bit to this, but if you know about diabetes, and I'm sure a lot of you probably have had some discussion about it, but this diabetes that's developed during pregnancy, also called gestational diabetes, actually increase your risk for having type 2 diabetes further on after birth, also increases your risk for high blood pressure and obesity. So what does that mean? That means that if you didn't have diabetes or high blood pressure or excess weight prior to developing gestational diabetes, you increase your risk even after you've had the child and your glucose levels start to decrease. And so gestational diabetes is an issue. Children born to mothers with untreated gestational diabetes face increased risk of neonatal death and long-term disability. A structured lifestyle change, like diabetes prevention programs, can actually help preconception and postpartum. So again, consider these type of strategies prior to mom becoming pregnant, because this can make all the difference in the outcomes for mom and also for baby. Excuse me. Now, this is a very busy slide, and I only put this up to show you that it's not just one thing, right? We can't just change one thing and expect everything else to happen and be beautiful. We don't live in that type of environment. So this whole life course, it's one thing is it's complicated, it's intergenerational, right? So if I grow up in a household where I'm used to cooking a certain way, I develop those habits and I cook a certain way, and so on and so on and so on. And so there has to be some opportunity to change that. So we talk about the epigenetics. And so we know that genetics can play a role in our health, but then there's also certain things that we can do to change our environment to change that course. And so epigenetics works both ways, right? If you change the poor habits or the poor behavior, you can actually improve upon those. So this is something to consider, that yes, the life course can be negative in some cases, depending on things like excess weight or type 2 diabetes. All of this can play a role, but there's also some positive, right? And if you look, everything kind of steers off. If you do this, you say, hey, I'm an adolescent with excess weight, I'm going to get better at increasing my activity and choosing better meal plans, then maybe I can start to change the course. Or maybe I'm already having excess weight issues, and then I start to have a large child at birth, and then I breastfeed, and then, maybe I can start to have a change the way my child eats, and I can improve their chances. So there's so many different things that are going on. Now let's move on to hypertension. Sometimes high blood pressure is present before pregnancy. In other cases, high blood pressure develops during pregnancy. So things like gestational hypertension, that's actually when women have high blood pressure that develops probably after 20 weeks of pregnancy. There is no excess protein in the urine or other signs of organ damage, Some women with gestational hypertension eventually develop preeclampsia. Then there's also chronic hypertension. And chronic hypertension is high blood pressure that was present before pregnancy or that occurred before 20 weeks of pregnancy. But because high blood pressure usually doesn't have symptoms, right, it might be hard to determine when exactly it began. And then there's chronic hypertension with superimposed preeclampsia. And now this condition occurs in women with chronic hypertension before pregnancy who develop worsening high blood pressure and actually protein in the urine or other blood pressure related complications during pregnancy. And then the last one I'm going to discuss is preeclampsia, which occurs when hypertension develops after 20 weeks of pregnancy and is associated with signs of damage to other organ systems, including the kidney, liver, blood, or brain. Untreated, it can cause serious issues and complications, even death, for both the mother and the baby. Previously, preeclampsia was diagnosed only if a pregnant woman had high blood pressure and protein in the urine. Now, experts know that it's possible to have preeclampsia without having protein in the urine. So make sure that when you yourself or when you're having conversations with your networks or your patients, that you're having a conversation and you're testing them on a regular basis. Well, this is going to be my last and my favorite slide. And why is this my favorite slide? Because I just had all of this conversation about the chronic conditions and how these are mainly what attribute to your to complications for mom and baby. And you even heard earlier this morning during the first session about the risk in Arizona, right here, in regards to racial outcomes. And that even despite the state's efforts, high rates persist for infants born to African American women compared to infants born to white women. And now scholars have identified socioeconomic status and demographic factors as a key potential explanation of racial and ethnic disparities in infant mortality. Furthermore, the lower the socioeconomic status of African American women relative to their white counterparts, due to the historical and continued influences of racism on educational attainment, earnings, income, and wealth holdings. These are all significant factors that also do contribute to infant mortality in regard to disparity. Now, however, once you control for these socioeconomic status, it offers an incomplete explanation. Several studies have actually shown a sizable disparity regarding race and ethnicity that was even seen after accounting or normalizing for SES. Elder and his colleagues found that controls for SES, like maternal education, demographic factors like maternal age, marital status, previous pregnancy loss, birth order, and plurality, and also prenatal health behaviors explained only 25% of infant mortality disparity between African Americans and white. 25%. Another interesting fact, infants of college-educated African American parents died at almost 2 times the rate compared with infants of college-educated white parents. Therefore, equalizing educational attainment across groups at that time did not eliminate infant mortality. Also, since we're talking about education, among college-educated women, US-born whites exhibited the lowest rates of infant mortality. US-born Hispanics or Latinx were slightly higher, and African Americans were substantially higher. What does that mean? White women, 2.9 deaths per 1,000, Latinx, 3.1 deaths per 1,000, African American women, 8.8 deaths per 1,000. So the idea that racism is a fundamental cause of health disparities operating across the life course to influence critical access to social resources and exposures, which then influence health, is there, it's true. However, and therefore there are inequalities in social economic status, access to care, behaviors. We know that all this exists, but we know that it doesn't account for the full picture. So what do we do about it, right? So what does being Black while pregnant mean? Well, to me, it means that racial disadvantage remains a cruel, punishing, and deadly phenomenon for African Americans in the United States. Even for those who have achieved very high levels of educational attainment. These factors are outside of the control of the individual. It's a societal issue. So consider this. Shortly after giving birth to her son in August of 2017, 27-year-old activist and Black Lives Matter icon Erica Gardner suffered her first heart attack. Erica Gardner, who entered the public eye in 2014 after a police officer choked her father to death for selling loose cigarettes, had an enlarged heart. The stress of the pregnancy and perhaps even the strain of her father's death further weakened her enlarged heart. 4 months later, she suffered another heart attack. This one put her in a coma, which she never awoke. On December 30th, 2017, she died. Although all deaths are tragic, I'm not demeaning that. Erica Gardner's death illuminates a devastating problem in the US. African American mothers are dying at 3 to 4 times the rate of non-Hispanic white mothers. And infants born to African American mothers are dying at twice the rate of infants born to non-Hispanic white mothers. These two trends hold true across educational levels and social economic status. Even worldwide superstar, tennis superstar Serena Williams, a wealthy and remarkably powerful woman, nearly died from pregnancy-related complications. And I'd like to end by saying, well, first and foremost, thank you for your time today. But I want you to think of some of these things as you start to interact and have conversations, and not always think that it's this or it's that, depending on the racial background of the individual. And then I also want you to consider some other things, like that women with chronic health conditions can, again, have very healthy babies. Chronic health conditions, as we talked before, include diabetes, high blood pressure, obesity, and mental health conditions. And as I mentioned also, partner with healthcare providers to manage chronic health conditions and treatments, including medicine, before, during, and after pregnancy. Don't stop or start taking prescription medicines before, during, or after pregnancy without talking to your health provider first. Plan your meals. Commit to eating healthier. Stay active and avoid smoking, alcohol, cannabis, and other illicit drugs. And in the words of someone that's very important to me, Dr. Maya Angelou, when you know better, you do better. And so protecting the health of mothers and infants is a critical measure of our country's development. By most accounts, the US holds the worst record for maternal and infant mortality in the developed world. Women in the US are 2 to 3 times more likely to die than Canadian women in maternal periods. Infants in the United States have 76% higher risk of death compared to infants in other wealthy nations. So there has to be something that we do, and hopefully by the time you leave this conference, I know I've been learning a lot, we'll have some of those solutions. So thank you for your time and your attention. And I will stop sharing my screen so our next presenter can begin.
Thank you, Dr. Gilliam, for that information and for helping us understand how we can support mothers in optimizing their health before and between pregnancies. Next up, I'd like to introduce our last speaker for this session, Julia Wacloff. Julia is the Chief of the Office of Oral Health for the Bureau of Women's and Children's Health at the Arizona Department of Health Services. And she's going to tell us more about how oral health can impact maternal and infant health outcomes. Take it away, Julia.
Thank you, Angie, for such nice introduction. And good afternoon, everyone. First of all, I'd like to extend a thank you to the Planning Committee for inviting me to present on this topic at such an important health summit this year. And I'm going to be talking with you about pregnancy and oral health. So pregnancy, as you are all aware, it is a unique period during a woman's life and is characterized by complex physiological changes, which may adversely affect oral health. At the same time, oral health is key to overall health and well-being. Preventive, diagnostic, and restorative dental treatment is safe throughout pregnancy and is effective in improving and maintaining oral health. At the same time, pregnant women, including some with obvious signs of oral disease, often do not seek or receive care. Health professionals also often do not provide oral health care to pregnant women. And in many cases, neither pregnant women nor health professionals understand that oral health care is an important component of a healthy pregnancy. So for these reasons, it is essential for health professionals to provide pregnant women with appropriate and timely oral health care and also education. And what do we know about oral health and prenatal care? We do know that 60% of pregnant women have tooth decay or gum disease while they are pregnant. Poor oral health can lead to poor health outcomes for the mother and baby. Pregnancy can make a woman more prone to periodontal disease or gum disease and cavities. And more than 75% of obstetricians and gynecologists surveyed had patients who reported being declined dental services during pregnancy. And the important point here that I want to share is dental care during pregnancy is safe and effective. As a result, oral health care during pregnancy brought together these three groups, prominent groups, to develop a national consensus statement. And this consensus statement is to provide recommendations for how we improve oral health care services for pregnant women. And they included the Maternal and Child Health Bureau from the Department of Health and Human Services, the American College of Obstetricians and Gynecologists, and the American Dental Association. And today I'm going to be sharing with you their recommendations that came out from this expert work group and panel. So historically, just giving you a picture of oral health in the United States, the mouth has always been treated as a separate part of the body for many different reasons. The payment systems are separate, the workforce systems are separate, the accessing care for oral health is separate. And as you can see, oral health is a gateway to the body. It's through our mouths that all our food, the majority of our food enters, right? We use our mouth to taste and smell, to feel and touch, to show feelings and emotions, and to speak and communicate. I've provided this graphic, and it really builds on what Dr. Lin and Dr. Gilliam were sharing about how oral health is connected to other chronic diseases. And you can see here, there's a connection to glaucoma, to dementia and migraines, to respiratory diseases, to cardiovascular disease, to acid reflux, to diabetes, kidney disease, rheumatoid arthritis, and the area of focus for us today, is preterm and low birth weight babies. So the recommendations that the consensus came forth with are: one is to assess a pregnant woman's oral health. So by this means if you're a healthcare professional, actually doing an in-mouth screening. So check for swollen or bleeding gums. Ask about toothache pain, if they have any problems eating or chewing food, or other problems in the mouth. Ask if they have vomiting and nausea. When was the last dental visit? Do they need help finding a dentist that will see them while they're pregnant? Questions or concerns about getting oral health care while they are pregnant. And then if possible, do a visual observation. Check the mouth for problems such as swollen or bleeding gums, untreated tooth decay, lesions in the mouth, signs of infection or trauma. The other component of the recommendation was to advise pregnant women about oral health care.